Perfect.
Okay, so we kind of broke up our parts and Stacy was gonna like introduce this, so I'm gonna fumble my way through this because it's a little different than what the title said. So it kind of looked like it was a lunch and learn on like communication milestones, which we are gonna kind of touch on. But we're kind of using this as like kind of a baseline to see like what everybody really needs support with. So this is kind of more communication domains and how to access the speech language pathologists in infant toddlers. So, and of course, there's some, speech therapists here, so speak up if you have like anything to add while we're doing this. This is like super chill, So, okay, so we kind of were like, all right, we don't want to just like talk about milestones and be like, here's what you do, this, and this. Because we've all been kind of doing this a while, so we feel like most of you probably are pretty good about understanding some basic ones, but we wanted to talk about why we might need to know communication milestones, situations that might be useful, how to access speech therapists, how and why you might want to access a speech therapist. And then kind of at the end, we'll talk a little bit about when you do need support, whether it's specifically milestones or questions that you have, what are the steps to do that? So that makes sense. So when do we need to know milestones? And then here is when we were going to kind of do like a little fun, like group participation. Again, Stacey was going to be the one doing this part, but so shout it out. When do you guys feel like it's important to know some communication or speech and language milestones?
Sound errors.
Okay, so sound errors during
Evaluations.
Okay. Anyone else? So what's that?
Eye contact.
Eye contact. Do you have questions on?
Like for when I evaluate like a baby, do they have eye contact? They're gonna be different.
Okay. So far evaluations, any other kind of situations that you guys feel like it would be helpful? Exit. Anyone else? We can just grow our list. Okay, so here's what we came up with. Determining eligibility at evaluations, obviously. Sometimes during sessions when parents ask about communication, at reviews, like 6-month reviews or annuals, at exits, before or after doctor's appointments. So sometimes you have those families that come back and say, I just went to the 18th month appointment with my doctor and he was asking all these questions and I don't know if they're on track. And you kind of have to access, well, let's see, what should he or she be doing at 18 months old? We also need to know when we're creating outcomes for IFSPs. And then if you want to know if bringing a speech service person is appropriate, so like a support person.
Secondary service.
Thank you, secondary. What am I saying? A secondary support person is appropriate. So again, you're doing your 6-month review. They have some questions. Is this something that you truly need a support person with? Do you not? So kind of understanding like where the child is at for that. And then as a child ages, if you have a child since birth and they're getting close to 2 years old or getting close to 2.5 and talking about transition, we may need to know some milestones for children, determining like next steps for development. So what is included in the SLP scope of practice? So again, we kind of went a little bit of a different route than milestones. And the purpose of what we're doing today is that at the end, we can kind of pick out some things that you guys might want to do like a further lunch and learn on to be more specific. Because we felt like if we were just here and laid out all the milestones, it kind of gets confusing. Some people have different ideas on different things. So we want to be as consistent as we can across the board. So talking about what is a speech language pathologist's scope of practice? How does that work into infant toddlers? How do we access them if we need help with those milestones? So any ideas about what our practice is? Oh, and also, I'm hearing certain things. So I heard like eye contact and sound production. So those are things that we're going to kind of gather at the end so that we can be like, okay, what do we need to know more about? Is there already info there to access, or do we need to kind of dig further into this as like a group during like the lunch hour? Okay, so what's included in an SLP scope of practice? So there's, and actually kind of introduced to us that there are, how many again? Nine different domains of a speech language pathologist, which I really like this graphic because we're like, oh, this kind of breaks it up a little bit. And it kind of gives us a good idea of like, what are the different things we should be looking at with in regards to communication. And of course, we know all of our disciplines, overlap. Thank you. See, there's that word finding problem I have. So we have articulation, which kind of is more of that motor speech. We have fluency and stuttering. We have voice resonance. We have hearing. So things like auditory processing, feeding and swallowing, social communication, communication modalities like AAC, cognition, and receptive or expressive language. And of course, all those things overlap because you can't have difficulty with expressive language without most likely affecting your social communication. Or you can't have difficulty with, or the possibility of having difficulty with like feeding and swallowing might overlap with like motor speech and articulation. So a lot of these things kind of overlap. So we were kind of talk about what are we looking for in each area? What are the things that we want to double check on with our children when we're serving them? And then you guys remember who's supposed to say what?
Yeah, you're doing this one.
Okay. That's good. So articulation, what does that mean? Because we can kind of use articulation or artic or intelligibility or sound production, those kind of different words. What exactly are we looking at when we have a child from birth to 3? So it's how we pronounce sounds and words. There's a variety of age-appropriate speech sounds that we kind of expect from them. We look at consistency of the speech productions. If they're maybe using, a particular sound, does it show up other, environments? Does it show up, the M sound, does it show up in different words during their speech? We look at motor planning for speech. Are they groping when they're trying to talk? Are they able to effectively imitate sounds? Intelligibility, how much we understand them, which leads into that frustration level and how it affects daily routines. And I feel like intelligibility is one that I use a lot when doing an evaluation. So like in the past 2 weeks, twice, we evaluated a kiddo with articulation, and a lot of times before 3, most of the speechers are pretty typical. Like we expect that before 3. But what's the consistency of them? How hard is it for them to motor plan for those sounds? And what's their intelligibility? So just asking parents, like, how much do you understand them? Asking about how much others understand them, asking about that frustration level, and how it affects their daily routine. We might have a kiddo that does a lot of final consonant deletion, but parents like, yeah, we kind of understand him. He's able to communicate with his peers. Teachers don't at daycare haven't mentioned anything, and he's not frustrated. Okay, we can take that into consideration when we're, seeking either an evaluation or if we think we might need help from a speech therapist during our services. The other one is fluency. So that's kind of the flow and rhythm of our speech. One of the biggest things we talk about at this age is what is typical developmental disfluency versus disfluency or stuttering disorders. So we're looking at the flow of speech, the ease of producing connected speech, and then the types and frequencies, whether they're repeating, the prolongation, which means kind of like making a sound last for a while, stops, blocks, and secondary behavior. So stops and blocks are kind of like when they get stuck on a sound. Secondary behaviors are some of those groping things. And at the end, we're going to talk about where to access information on this so that we know, I think this child is stuttering, but I don't know if this is typical at their age or not. So that's something we would want to know.
Maybe I might just type into if you're talking about articulation and the word intelligibility.
Yep.
Just a disclaimer, most parents think that we're talking about intelligence when we say the word intelligibility. So I love how you defined it. How much of what he says do you understand? I would definitely encourage us to not ever use the word intelligibility.
Yes. Yes, unless it's in connection with like describing what it means or something, or,
Yeah.
Absolutely. And we can all ask that in different ways, because as we know, when we serve families, every family is different. So how we explain things and how we ask questions is going to be different. So it's really hard to say, this is how you need to ask about intelligibility during an evaluation, because it's really just going to depend on the family. I feel like if you have some struggles with that, reach out to a speech therapist and we can kind of talk about it. But most of the time, you know, some families I might say, well, during the day, what percentage do you understand them? Above 50% or below 50%? Because maybe they need more of a specific idea in their head. Some other families might just say, yeah, I understand them most of the time. Or you might be asking like, how many times a day does he get upset if you don't know what he wants? Things like that. So it kind of just depends. Usually it's kind of in the moment.
So the next area that we're kind of looking at is that voice and resonance piece. So resonance refers to the vocal quality that results from those sound vibrations within the mouth, nose, and throat. And then voice refers to how we use our vocal folds and our breath to make those sounds. So a lot of what we're looking at is if a child is hypernasal, where they're producing most of their sound within the nasal passages, or if they're hyponasal, where none of the sound is kind of getting up into the nasal passages. We're also looking at their voice quality. So is when the child's talking, is their voice really breathy? Are the sounds that they're saying really harsh? Does it sound raspy, strained? Those might give us some ideas of when it might be appropriate to refer out to get a consult to see what might be going on medically there. And then just some causes that might impact that voice and resonance in early intervention can include if a child has cleft lip and palate, because that is opened, their sounds might not be resonating how we would expect for their age. Some syndromes, including Down syndrome, can impact that voicing and resonance. If a child has laryngomalacia, they might, which is a congenital softening of the larynx, they might present with stridor on inhalation, which means that they're making like a high-pitched whistling sound whenever they're breathing in. Some other things could be nodules or damage to the vocal folds. Sometimes we see that if a child has to be intubated, sometimes that can impact that. If they have enlarged adenoids, we see that a lot as well. They might be mouth breathing, snoring a lot, which can kind of alert us to some other things. And then if they have allergies or respiratory infections. So those are just kind of some things that if we're seeing those voice and resonance differences, it might alert us like, hey, there's maybe something more medically going on here.
And just I'll point about that real quick.
All right, so
No, you're good. So again, this is kind of a perfect example of like kind of why we're starting this way with this lunch and learn, is we don't really expect every person in early intervention to know all these things. Hannah explained it well. I probably could not have explained it as well. And so we've just identified Hannah as someone we would maybe look to for a speaker. But the nice thing is, you know, maybe we don't see this as much in early intervention, but it's good to have on our, you know, back burner in our head. So we kind of wanted to go over all these areas so that we understand, like, these are the things that we're looking for with speech language pathology, and these are the things that why would we access maybe a support service with, you know, a speech therapist.
So another area that we're looking at is language. So that's the words, phrases, and sentences we use, and then how we use them to share ideas to get what we want. So I know a lot of you are probably familiar with both those receptive and expressive language pieces. So receptive, how the child is understanding language. Generally at this age, with our population that we work with, we're looking at their ability to understand and then what it is that they are understanding, or if they're having difficulties with that understanding. With expressive language, we're kind of looking at what words are they using? Do they use gestures, signs? Are there other forms of communication that they use in addition to speaking those words? And then kind of moving beyond some of that symbolic communication to increase those words that they're using. We also take a look at vocabulary, so what number of words does the child use? A lot of times that's what we will use for that eligibility piece. And then also kind of looking at the types of words and then how they're using those words. So is the child just using it to label? Are they using it to request, to comment? Kind of doing some of that back and forth communication. So lots of time looking at like that function of the communication, and then also kind of thinking about what type of language development is this child kind of fall under. So there's two types of language development. There's analytic, which is kind of considered that like typical language development, but both types are normal types or normal ways to develop language. So analytic is when a child really learns language by single units. So a lot of times gathering those single words and then building upon it. So it's kind of that bottom up. So they're starting with those really basic levels of communication and then building up to 2-word phrases, 3-word phrases, sentences, stuff like that. And then gestalt language is when a child learns language in chunks. So they're kind of using phrases, sentences, and using those as scripts. So a lot of times I think of it of like, if a child really likes Toy Story, they might say into infinity and beyond, and that phrase has lots of different functions. So it could mean like, let's go, or like, I want to play, or like, it's time to eat. So those children are using scripts or things that they're hearing frequently and kind of assigning those to multiple functions or forms. And a lot of times we see that in the autistic population, but not all children with autism are gestalt language processors. And children that don't have autism can also be gestalt language processors. So it's not like a one size fits all type of thing. And then we're also just kind of looking at our children starting to put those words together too. So those are just some of those things with language. I don't know if anyone else can do that. Cool.
And the analytic versus gestalt language development has kind of always been something that we've talked about in speech language pathology world, but I feel like lately, just with like more neurodiversity affirming practices going on, it's definitely gained a lot of popularity. You know, a long time ago, we would say that there was something wrong with a child if they were learning language gestalt. Now we're seeing it as a typical way of them learning their language and then working with that in a more affirming way versus trying to force them into the analytic box. So lots of information and info going on with that. I know that some of us are looking at doing the gestalt CEUs, and so hopefully we'll be able to kind of expand that knowledge to everybody and kind of like have that in the back of our head during evaluations and working with children who might be autistic. So anyway.
And then another area that we look at is cognition. So during evaluations, I know that we all look at how kids are playing, how they're problem solving certain things. So, you know, if they can imitate some play that we do, that's usually what I try to look at, just to see if they can imitate, and then to see if they can talk on the phone with, I don't know, a block or something like that. And then just also looking at different skills, like if they're singing along to songs, or if they can go find something that we say, look over there, look what's under there, things like that. And then as far as hearing, we all do the hearing screen at evaluations, but just really making sure that we know how many ear infections that the kid has had. If we know that there's fluid in the ears, and then if there's like some receptive language processing, that's a little bit trickier for the kids. We usually try our hardest to refer out to a hearing specialist or an ENT, which I know Casey and Lynn will talk about later. But yes, because usually that hearing, I mean, we all know hearing impacts language. So yes.
And I feel like in the evals, it can sometimes be hard to break down, like, is this a receptive language delay? Is this like something that we're seeing due to hearing? So that's why those hearing screenings are also so important, to just rule out that medical piece as well.
And then for feeding and swallowing, I personally feel like I look at just making sure that they're not coughing after they swallow. just because I feel like we learned a lot about swallowing and not so much like the actual feeding aspect. But we're also looking at, are they lateralizing their chew? So moving their tongue back and forth. Are they actually chewing with the sides of their mouth instead of just the front of their mouth? Recently I've had a lot of like tongue thrusting, so pushing foods out instead of chewing on the sides. So if parents have concerns for feeding, then I ask a lot of questions about chewing. And then also seeing if kids are eating a variety of different textures, and not just like one thing like puffs or Cheetos or things like that, even though those are really great. And then the next one I think is, so there's two more. As far as social communication, it goes along to expressive communication, but we can also socially communicate without actually saying words. So are they waving hi or bye? Will they take a toy from someone? Will they hit someone? Like that's a social communication also, even though it is a behavior. They're communicating in some way. So just thinking about how many gestures that they're using, if they're using any facial expressions, like if they're scared or like if something surprises them, seeing if they do use any form of eye contact, and then seeing if they attend to you with their body, like maybe not necessarily eye contact, but moving their body towards you. If you're trying to call their name, like seeing if they'll turn to you instead of just with their back against you. And then sustaining some interactions with peers. So maybe that is that back and forth. No, that's mine. No, that's mine. Things like that, which is typical. And then as far as communication modalities, we look at lots of different areas that kids might need an augmentative and alternative communication system. That doesn't necessarily mean it has to be high-tech AAC. So if you think about high-tech AAC, it's usually those iPads with an app, or usually like different things that can communicate for you, and the kids select a button and then it has communication output. But there's also different kinds of communication modalities like pictures or sign language, different things like that. And so during evaluations, if we're not necessarily doing an evaluation for a certain type of communication modality, but I'm kind of thinking if like we walk in and a kid has, I'm just gonna say Down syndrome, we might think in the future, do we need an AAC device or do we need some type of visual system that the kid can process a little bit better and can be able to communicate without getting frustrated. So we're just really looking at honoring all kinds of forms of communication and supporting kids in that way. Yeah.
Okay, so those were kind of the 9 modalities that we wanted to kind of touch base on. And so kind of thinking about those, you're gonna, obviously we'll have access to what's that thing called? PowerPoint, thank you. Access to the PowerPoint in SharePoint. And what we want to encourage is looking at all of those things, kind of identifying within yourself, like, what are the things that I would like to learn more about? What are the things I feel really good about during evaluations or during reviews or, you know, during exits? And then kind of how do I access support if I need some help with some of those areas? Or if I have questions on what I know what I'm supposed to be looking at, but I'm not quite sure if this is typical or not. So what we kind of want to do is talk about identifying team members' areas of interest and experience. And so that's one of the ways you can access that information is by, peer to peer. This was also kind of a question when Monica introduced that peer to peer coaching, what are those areas that you want to kind of strengthen? What's that area of interest that maybe you don't know about as much and you'd like to know more of? But also identifying within yourself, like what your own areas of expertise you feel like you have, so that you can put yourself out there as a support for others. So our questions, we're just kind of playing around with this. Feel free to answer if you want to. Have you found people on your team who have helped to support your knowledge in any of these 9 areas? So thinking about, the teams that we have and the access you have to the speech therapists on the team. And also, identifying within yourself, have you found people on your team that have helped to support your knowledge in these areas? Do you want to
And I
like
think-
that?
Yeah, I think also kind of thinking beyond just speech too, because there's a lot of overlap in
Yes,
all of these
obviously.
areas too, so kind of thinking too, like what other disciplines can be helpful with all of these areas.
What do you want to answer?
Go ahead.
So, I feel like anytime I've had a joint visit with an SLP, it's always really helpful. I feel like I'm fair without being an SLP, feel pretty well versed, helping like support that early language. I think what I run into, and maybe it's a little bit of lack of confidence, is, and I've taken kids before that are language and sensory, and it's been good, but it's kind of, I think it's more like education about our model, like to the families, like, oh, you're gonna help with this, that you're an OT, so I don't know where, if that comes in.
So kind of how to discuss or explain with families overlap between
Yeah,
disciplines in early intervention.
yeah, and then maybe just also just being confident that I do have the skills at least to get started, but then I feel like I do, but then I start talking to families and then, and then sometimes like if they go to a doctor, if they go to, certain things, they'll have a request for, so I just don't know how to navigate that always.
Yeah. Well, and that was kind of what we were talking about, that's the perfect example of like why we wanted to do this today, to kind of identify within yourselves needs of support or extra things that we might need to talk about. What areas would you like support from the team to increase your capacity? So that's exactly it. So everybody is going to be different. One person might be more comfortable with one thing versus another. So as a speech therapist, when I think about OT things, I'm more comfortable not needing support in like the area of sensory versus feeding. So kind of knowing what we need to know, when we need to know it, and how to access it when we realize we need to know more. What was the next one?
Those were the 2 main questions.
Oh, okay. So kind of just thinking about these and then like relating it back to the 9 areas. I'm just writing notes as I'm on my phone. So one of the things I wanted to, or Stacy wanted to kind of bring up too, was like, if there's something that like is really kind of burning in your brain, we could certainly discuss it today, but also if there's anything you're like, I would really like to do like a lunch and learn on this, or as a group, do this a little bit, more in depth, we can kind of make sure we create that a spot for you to let us know, and then we can kind of see where to go from there. But before we do that, we wanted to talk about the next slide, which is the resources for supporting and building team members' capacities in communication. So these are the different ways we are already trying to build our capacity with understanding communication and how it relates to early intervention. We use primary coaching. We have the resource folder. We connect after team meeting with others. We do joint visits during and after evaluations. And then, of course, referring to the CDC milestones. We kind of were talking about the resource folder, and I know it can get really confusing because there's like a lot of information. And I wanted to talk about how the resource folder isn't there for you to find the information on your own. Being able to use it with your peers. So maybe connecting after team meeting and, if somebody says, oh, like the other day at team meeting, I was like, oh, I'm pretty sure there's some potty training handouts in the resource folder. Well, maybe going with someone looking at that folder together, or I know there's articulation charts in the resource folder under speech. And so if that's not your discipline or your area of expertise, just looking at it, we're not relying on the handout for you to be able to explain that to your family. We want you to reach out to a speech language pathologist in order to access that information together. And then after you do that a couple of times, maybe you will feel comfortable doing that on your own. But we wanted to let you know, like, these are the ways that we want you to access having support people. It's not just, can I have a speech therapist come with me? There's a lot of things we can do that we try to do before that. And doing that in conjunction with bringing a speech therapist out is also fine. But one of the things I thought about it was like, sometimes I'm kind of looking at the resource folder on my own, just kind of playing around with it. And I feel like I would need someone to be with me doing that, to kind of explain some of the things that aren't like my expertise, so.
And I might chime in here
Yeah.
too, thinking about like our primary coaching and what we heard from Dathan and Melissa, back in August was, you know, the idea of early intervention and teaming isn't to make, I'm gonna pick on Isabel because she's right in front of me. It's not to make Isabel a speech therapist. It's to make Isabel dangerous enough to know just enough that she needs more help. And so, you know, really when we think about, I hear a lot of questions, well, you know, I'm an OT, I want to know what language milestones a child should be doing at what ages. That's what your team is for. You've got 9 SLPs on your team. And so bring those questions to team, because I guarantee if you have that question, probably another OT or a PT or a social worker does. So again, we don't have to know everything about everything. That's the essence of teaming and using one another. And is Lori Arndt in here? One of her favorite little, I feel like, little sayings about team meeting was she just gained little nuggets of information over time that over the course of teaming for 12 years have made her know a little bit more about a lot of other things. That's what we want to keep doing. And I feel like that's what we're not doing a great job of, because we feel like we're supposed to know it all. And really we're not. So again, bring those ideas and, you know, questions about what an 18-month-old should be doing, and let us coach you without doing a joint visit and just saying, hey, this is on track, or this sounds like, yeah, you might want to keep an eye on it. So again, I love that you put primary coaching first. That really goes along with everything that we heard in August and everything that we're trying to do.
Yeah, and I think that was kind of our hope with going over those communication modalities. I mean, obviously, that's nothing new to anybody here. Like, obviously, most of that stuff you kind of probably already knew, but just like a good little reminder of like, here are the things. And then as you go through that, are there things that are sticking out in your head? Like, I'm sure I know whenever I go to a lunch and learn or doing anything, I always have like 2 or 3 kids in my head. I'm like, oh, that relates to this kiddo. So sometimes that is hard because then you're like, I just want to bring this kid up for primary coaching. But really, when you're doing that, you're also increasing your own capacity for the next few kids that you might see that are similar. So we were hoping going kind of over that in kind of a bullet point way. I don't know what the word I'm looking for. Structured, that's the word. In a structured way would help kind of in your heads kind of figure out, okay, where is it that I need support with knowing some of these things versus I'm good, or versus, okay, I'm going to reach out to someone for some primary coaching. Yeah, and I just really like the idea of using the resource folder in a better way. But that's my thing that I keep thinking about.
So I guess with all that information that we just threw at you, what questions do you have?
Or thoughts, or just like something that's coming to your head, like, hey, this isn't really what I thought we were going to talk about today. Here's what the question I had coming to this, etc.
And I might circle back to Lisa's question
Yeah.
about when you feel like as a therapist, you know enough to be dangerous, but you have a parent saying, I want a speech, or my doctor says I need to have that. We're in a very educated community that knows a lot about a lot of different things, versus if we were in Garnett, Kansas, we may have a team of 3 people and that is it. So I think that we struggle, right, with implementing the approach, the model as we're supposed to, with also being in a very educated community that is full of resources. So the one thing I would always keep in the back of your mind is what, you know, teaming is not about keep away of services. So if a parent is asking for something, you've given the information that you have, again, come back to the team. Let's not keep that away from the family. There's really no need. And I can pretty much guarantee I'm gonna come out with you and say the same thing you've been saying, and then that just helps build that confidence of that parent that, yes, Lisa's an OT, but she knows what she's talking about. So again, how can we build that confidence of the parent by joining you for a joint visit and reassuring more than anything?
And I really like the idea of using our joint planning tool before a visit, as much as we can, because again, that's building our capacity as a primary service person for that family. So without feeling like I'm bringing, Hannah in so she can explain this to you. It's more I'm bringing the support in as your primary coach, I'm able to give you this information. So.
I can only speak for our South team because I've only been a part of those team meetings, but I feel like we do a really good job of predicting next steps or like thinking about next steps without the parents doing that. So sorry, Lindy, I'm just gonna say Lindy. So like if Lindy is working on motor with the kid, she'll come to team and say like, what things should I be looking for this kid for language, or like, what are the next steps? When should I bring out as someone to support for language, things like that. So I think everyone already does a good job about that too. So on my team, I'm sorry. I'm sure everyone else does a really good job too.
He's comment about the joint planning tool, is that a thing we could do with the family? I can't remember all of the questions that are on it.
It's designed to do with the therapist.
Okay.
But it doesn't mean that you as a primary shouldn't be saying to a family, what would you like from Nadine when she comes? So, like, again, you're coaching the family, even though you might already know and have told them everything they're asking for, because we know that happens. That's really how that tool is supposed to be used. But I think there are some great questions on it that you could go through with the family to make sure you're communicating that to your joint provider.
Makes sense. Anything else that you guys feel like we didn't touch on?
Not that we didn't touch on it, but within that resource folder, because I do go to it a lot.
Uh-huh.
Is there, regarding articulation, is there one chart that you would feel comfortable, like CSEs or OTs or whomever, to look at and use like one more than another? Like I just was kind of going through the Arctic and all the different resources related to that in the folder, and I just don't know, like, what would you say is as the
So
therapists are the best ones to
Right.
really use?
you can answer if you want, but I would say, stop me if you,
I'm sweating, so let's.
okay. I would say that is a perfect example of why we did this, because that is the time that I would say you would reach out for some secondary support from a speech therapist. That is the perfect example of like, I'm not really sure what I'm looking at. I'm not really sure which one's more accurate. I'm gonna reach out to a therapist on my team and kind of go over that with them. Because we don't expect you to be like, oh, that's the articulation chart from 1998. Sure, I'll use that. Like,
I know.
even as speech therapists, there's so much information that we can't keep track of. And each speech therapist approaches articulation differently. But we're all within the realm of evidence-based practice and using our professional, judgment. Thank you.
You're doing great.
Yes, so using our professional judgment. So again, I can't go to the folder and say, use this one. I mean, I don't even know what's, I mean, honestly, I don't even know what's in the folder right now. I feel like as speech therapists, we met like maybe
Yeah.
So
a
there's
couple,
There's
at least 6 months ago, we kind of talked about pulling some out of there.
there is a specific one that is the most up to date as far as research that
Yeah.
I feel like as CFs last year, that's what we learned about through grad school. It's like McCoy and something 2020, I don't know.
But it's hard to interpret.
It's hard
Yes.
to interpret, even though there is a family friendly page in the resource folder with that, I'm like, okay, well, the trees don't make sense to me. So, like, if you look at the visual and things like that, but
Yeah.
kind of what Nadine was saying, I feel like even I would need to like go up to Hannah and ask questions about exactly what I'm looking at within that visual, because it is so, I don't think it's family friendly, even though it looks like a tree, you know.
And our services are so individualized to our families that certain ways of presenting information to families might be different depending on the situation. Also, kids are different. So if one kid, again, has final consonant deletion and another kid has final consonant deletion, we're not going to treat them similarly. It's really going to depend on a lot of other things. And maybe there's some fluency or voice we're looking at, or some oral motor things we're looking at, or some social communication we're looking at where it's really affecting their social communication. And maybe that's what we could bring in, versus we could tell both parents, that's normal till 3, don't worry about it. Or tell both parents, nope, we should be working on that. It's not always going to be the same. So accessing peer-to-peer support from each other is really going to help us get through that. And then if you come across families that are like similar, you might be more comfortable being like, oh, I could share this and say this because I know that's what it's worked for another family.
I
Thoughts?
get a lot of questions about what's involved in sound connections. I work with a lot of kids with expressive language delays, so I just want to make sure I'm saying the right things and then bringing in people when I really need to. I don't want to wait till it's, farther down the path and I should have
Yes.
reached out
I
and.
think we wouldn't wait, and you have to think about, like, what are you licensed in? What was your own training? Like, I don't know when a kid needs AFOs. I mean, I can tell if they're walking funny, but I would never try and do that by myself. So I think we have to think about our personal and professional licensure and training, and we have to say, okay, is this something I'm qualified to say this? And I am not qualified to speak on adaptive equipment for motor delays at all. So again, bring it to the team, because they're, like, you guys have done a beautiful job. There's 1,000 different things. Like, kid might be able to say a D when there's an E behind it, but not an O, and that's a articulation kind of thing. And
Yeah.
nobody but a speech therapist should know that.
Yeah.
So I would say, you don't have to know everything. That's a great question. Let me take it back to the team and I'll bring it back. And again, it allows you to keep building that capacity. So the next time a family answers, you've got a little bit more information than you had the last time. But I think if that resource folder is a lovely idea in theory, it's a disastrous idea in reality.
Yeah.
You cannot find anything that is actually helpful.
I almost feel like we could rename it versus resource, because I feel like the word resource makes you think like, oh, I can go there, grab a resource and use it. And truly, it's kind of not, sometimes you're not able to do that. And you're going to find like, this is something you're coming across a lot. So you may feel like I'm constantly asking the same question over and over again, but that's what we're supposed to do in learning to be an early interventionist. I mean, even now I feel like some of my knowledge goes in waves. And so for a while, I'm really good at this, but I'm asking a lot of questions about this for a really long time from my joint visits and from the other disciplines. And then after a while, I get a little bit more comfortable with it, but maybe I might not see that particular thing for a while and then have to relearn it all again. I think that's just the nature of early intervention. So feeling comfortable saying exactly what you said, I don't really know which one to share with families. That's okay. So, and you might ask like 4 or 5 times. That's all right too. So, anything else?
No, and I'm talking a lot here, but I hear things from different teams. One of the pieces I love that you guys spent some time talking about was feeding. Historically in our organization, OTs have done feeding, period. And that's not really how it is in other areas and other parts of the country and even in Kansas. So I think it's really important to come to team and ask for a consult with feeding, but maybe not ask for an OT to join you in feeding, because we do have SLPs and we've got Dana, and sometimes feeding is behavior and ECSC can help. So I think really once we come to team and we've earmarked a discipline, because it's in our brains, we've eliminated a lot of other therapists that have a lot of other knowledge. Now, if a family has said, I want an OT, clearly that's important information to share with the team. But I hear that a lot, you know, I want an OT to do everything, and I've got an SLP sitting next to me that has just taken 7 CEU courses and really wants to practice, that doesn't have that opportunity. So I think that's an important piece too, because it is something with our scope of practice and training that we're able to do. And it makes a great fit, right? We've got OT and nutrition and speech and behavior. I mean, like you've got all the gamuts of, you know, one type of adaptive skill.
Okay, so we're gonna switch it over to hearing screenings. Should I just let the Zoom run or should I try to pause it? You know,
Let it run. This is
Okay.
exciting.
I'm like trying not to like my face.
Hey, everyone. We're ready to talk to you about hearing screening. Okay. Great. So we're gonna kind of talk through what hearing screenings look like and what we do so that you all have a better idea of what happens at a screening. So then if you're signing a family up, you can kind of talk them through that process, or if they have questions, you at least like have seen what it looks like. So we're gonna start by just actually doing a demonstration. So would one lucky participant from the audience like to come up to get, oh, Luke, wow. Okay, Casey is going to do the screening and I'm gonna kind of talk you through what she's doing. Onions and red onions. Okay, so Casey is starting with the tympanogram or tympanometry. So what this is doing is it's going to check Luke's middle ear. So that's where ear infections and fluid can occur. So she's just going to do it. This is really about just like getting a good feel, and then we'll get a readout on this screen. I brought the biggest one.
You do have.
Honestly, our probes are designed for children.
Right.
So we'll see everything.
All right, well.
Not working. Anybody, this is also, it's live, it happens, sometimes it happens, and we say, what are you? Yeah, and that's why we just get into team, because sometimes it's tricky. So it's flashing green when it's ready. So you get a good feel. Too big. Yeah, it's going all the way.
Yeah.
You can try, if someone has small ears.
I have small ears.
On our- Sorry, Liz. Thank you. The new program, right? Okay, so this is all about getting the correct feel. So like, as you can imagine, our kiddos are not as good at sitting still as Otter is. So like, again, like giving that sheet of what to expect, which we're gonna talk about later, is really helpful. So we need the kiddos to sit relatively still so that I don't poke their ear out. And so that we can get that good feel. Okay, so maybe we can't do this on anyone because Honor also has too big of ears.
But essentially, that's what it would be, like, it's real quick, it's.
Yeah.
But so what we
5
do, yeah, we put it in
here,
there, we get a good seal, and then after that, we get a readout on this screen, which you obviously can't see because it's tiny. But what we're looking for, there's a box, and we want like a nice triangle with a nice peak in the box. If it's under the box, or it's just a flat line, or it could be like a little bit rounded under the box, that basically indicates to us that there is fluid in the ear, which we don't know if it's infected or not, because we're not doctors. But then we would refer them to their pediatrician because they likely have fluid. So that's what the tympanogram does.
I'm gonna do the OAE.
Oh, sorry. Okay, so that's the tympanogram. Again, that's checking the middle ear, and then this is the OAE, which stands for otoacoustic emissions screening. So what this does is it's checking the inner ear. So it's checking the cochlea, which is the part of the inner ear that talks to the brain. So what this machine does is it sends some beeps that are different frequencies or different pitches into the ear. And then if the inner ear is working correctly, it's gonna send an echo back out, and the machine can pick up that echo and it tells us, yep, this ear is working properly. So this only tests 4 of the higher frequencies. So again, it is just screening. It's not as thorough as like an actual, oh yeah, sorry. You have to be quiet, so I'm gonna stop talking.
No, I'm sorry. So this one will sit in each of her ears. And I'll show you about how long it takes.
And they cannot be crying during this.
So it's starting now. Congratulations. you got it. So it is quick, 15 to 20 seconds. And then you'd of course do that in the other ear.
We get a lot of grabbing. We don't like to have to restrain the children. Some parents are like, oh, hold them down. I'm like, "Mm." So we give it a little bit, but that's where like the what to expect letter really is extremely important. We can tell the kiddos that have come in that have practiced. It's pretty evident. So always, if you are signing somebody up for a hearing and vision, pass this along to the family when you do that.
Whether that's an email or a paper copy, either one. But yes, again, like you have to sit still. If there's like a lot of movement, if there's thrashing, the machine can't get a reading. If there's crying or screaming, or any like loud talking, the machine will pick that up. What else? Basically, so think again about our kiddos. They're not usually great at that, so that's why that practicing is really helpful. Okay, thank you, Honor. So those are the 2 screenings that we have, and we go over the results with the families afterwards. And now we're gonna hand out, we came up with a new flow chart because I know we have changed, like, who should you refer 1,000 times and where should you refer them? So there is a flow chart or decision tree to help you with that. Okay, we're gonna pass this out and then we can kind of walk through it. I'm gonna see this go today. Really sorry, we didn't know we're gonna need to.
What?
Everyone get one in the back. So we designed the hearing screening decision tree basically just to help guide us as we're going through that initial hearing screening at an evaluation and kind of determining who is the best fit for our hearing screenings versus who should maybe be referred out. So Monica assisted us in this, and then we also had Erin Schuweiler from PDG kind of took a peek at this with us. But how it flows is at the top, you'll see kind of that first step, did the child pass the paper screening at the initial evaluation? And then obviously you'll flow down based on how you answer each of these questions. So if the child did pass the hearing screening, we'll go to the left first. There's further questions to know, are there concerns related to like hearing or fluid in the ears? So we all can kind of reflect back on that hearing screening, that paper screen, which is designed by the state. And so we're required to ask those questions, but some of the questions you might find like, oh, well, I think this is more of a receptive language thing like Hannah was talking about, or there's definitely cases where it seems like there's something maybe medical going on here, or, you know, it can go a variety of different ways. So again, this is kind of designed to hopefully help answer some of those questions, but sometimes we have cases where the child passes the paper hearing screening, but we're still kind of questioning that. So looking at, are there concerns for the child's hearing or fluid? Again, you factor down again, yes versus no. If no, then we would say no further screening or evaluation is recommended, continue to monitor that, and then refer to our ITS hearing screenings as needed, or if the parent requests a screening at any time. And then you would update that hearing screening again at the annual review. If there were concerns with hearing or fluid, even though the child didn't pass the paper screening, or did, excuse me, pass the paper screening, then there's going to be a set of follow-up kind of questions to reflect on. Does the child have any medical diagnosis or diagnoses, I guess? Have they had 2 or more ear infections or a history of chronic fluid? Is there a family history of hearing loss? Are they already being seen by an ENT or an audiologist? Have they spent more than 48 hours in the NICU? History of CMV or suspected autism? If you answer yes to any of those questions, we're recommending that you refer to audiology for a full hearing evaluation. Technically, this is just a screening, and so to make a child go through another screening in order to likely refer them on, just kind of seems like a waste of time for the family, and maybe waste of resources where we can connect them with that specialist. Anything, Monica, that you would add to that description?
And on the back in the contact information for KU and CMHC for audiology, if you do need to refer a family there.
Oh, and I can finish the 5 minutes if you want to. Sure. And then of course, if you answered no to any of those questions, then that would be a great candidate for our ITS hearing screenings. And we just kind of put in parentheses, this will most likely be children with language delays, but that might not always be the case. So there is in that blue notes box at the bottom. If you have questions, please feel free to connect with any of us and we can kind of walk you through maybe what might be the best next step. And then Lynn's gonna go through the other side.
Yeah, so if you do that paper hearing screening at the evaluation and the child does not pass, then you're going to go down, to the right side. And then that first set of questions is the same as what you saw on the left side. Same things, any medical diagnoses, 2 or more ear infections, all of that, and then you all can read. So you go through that, and then again, if any of those were a yes, then again, we're gonna refer you back to audiology because there's likely like more of a medical component going on that is above our skill level. And then if the answer is no, then that again is a good candidate to refer to us. Again, that's mostly going to be those kiddos with language delays. And then we have a couple notes at the bottom. So we would like to move away from scheduling hearing screenings at evaluations. We know that there's already a ton of information being given to parents. We're already rushed for time. Let's just wait and have the PSP or the FSC or FSC that takes the kiddo on do that with the family. And then that person can be in charge of following up with them, hearing or sending out that what to expect letter, all of that. We also would like to remind you, like, if the child is going through that transition process with Part B soon, and they are going to screen their hearing, so like for Olathe exam, for example. They always do hearing and vision screenings at Olathe, so if the child's getting really close to that transition time. There's no need to come to us to do it. Olathe is gonna make them do it again because they have an audiologist on staff, but just kind of be mindful of how old the child is and where they're at in that process, and don't send them to us if they're doing it another way.
Question.
Yeah.
If we've done what they passed, doesn't the school district just take that and?
Not always.
I
It
feel like
depends on the district.
Olathe does, specifically Olathe, they want their audiologist, is what I've heard, that's feedback I've gotten. I don't know about the other districts.
Depends on the district. Some don't even
Okay.
do a screening, some just review our paperwork, some do their own. So that might be something to just think about and dive a little bit more into. That's a great question at the transition conference to
That's
kind of.
helpful to know, because as the person who was evaluating, and if we saw a reason to refer to ITS, but we didn't. I feel like I didn't do my job, and it just was like, oh, you haven't done the screening. So, thanks, that just helps to know that.
I do know that most districts will take, information if the family has gone to KU or CMH and seen audiology at either of those places. It does have to be, I think, within like the last 6 months. But that they will take, and then you can bypass the screening with the school district.
Okay, thank you.
Yeah, and then the last thing is just to reach out to one of us on the hearing screening team, if you have questions or if you have like a situation that's not easily described or doesn't fit into any of these boxes, just reach out to us with questions.
Take it to primary coaching.
Or take it to primary coaching. Great plug for primary
Good plug.
coaching. Yeah,
A question about how to walk parents through. Because I don't believe that most kids have to have a referral to be able to go to audiology, correct, from their doctor? So may I ask, like, whenever you guys, because I fully agree, whenever you guys are suggesting. If they've had 2 or more ear infections, regardless of how many they've had in so many months. How do we help educate our families whenever they're hearing their pediatrician say, oh, well, they have to have 5 in 6 months before we will refer you? Like, how do we navigate that? Cause I'm pro go. They're quit messing around. They're trying to learn their language here.
Do you feel like you're finding that with audiology or more so ENT? Or both?
No, pediatricians
Or I mean,
say,
like, though, that they're not wanting to send them to audiology, or they're not wanting to refer them to the ENT until they've had a
not
number.
wanting to make any decisions until it's reached a certain number of ear infections in a certain amount of time, period. So I guess I'm just I am always encouraging my families. You know, they're at this critical late stage of learning their language, and you know, we're obviously in there for other reasons. You know, let's just make sure that this is taken care of, but I don't want that to sound undermining in any way to the pediatrician, but I'm not gonna lie, there's been some situations where I'm just like, are you kidding me? So I guess I'm just trying to figure out, like, what's the best way to advocate and encourage our families? If we're saying 2 or more,
I think that's what you say, you know, based on, you know, if you're seeing any delays in language and there is a history of ear infections or fluid. Best practice is to get that hearing evaluated.
Okay.
Where I see pediatricians dragging their most is making a referral for ENT. That's the one where they seem to want X amount of ear infections of X amount of time. But I will say this, I know that the hearing evaluations at Children's Mercy and KU are backed up.
yeah,
Quite a bit. So, you know, that would be another piece to consider, but, if they've got a lot going on medically, a hearing evaluation should have already been done theoretically, right? Still in theory. But that's how I would approach it. If they're, you know, if you're seeing delays in language and there's a history, because sometimes it's the, fluid that impacts the hearing more than the ear infection.
you can't see that they have it.
Right, yeah, because, yeah, they're not sick. Yeah, and I think that's, and to your other question too, I think it depends on families' insurance. Some need a referral before they can get it, some don't. So I think you're dealing with the insurance world, which is above and beyond our pay grades, so.
I think too, sometimes I'll tell families that. The difference between ENT and audiology, they may not understand, and I could say like. Well, I recommend getting the hearing evaluated, look into insurance, make some phone calls, talk to the pediatrician. And it's not really undermining them because you're not saying, oh, he needs to go to an ENT.
Right.
So that could just be like the starting point. Let's get his hearing checked.
I'll say I had a parent came out for consult for a little guy. They had some fluid and things ongoing that mom had brought up and mom and I had talked about a lot. And her pediatrician was very much a wait and see. And Eric, I think you reached out to the pediatrician after our consult. Yeah. And then it was like the pediatrician was very receptive and got things going. So there's a little extra rules, not to make more work for you guys, but it was really helpful.
And I do, Monica already kind of touched on this, but I do like to tell parents that even if kiddos have fluid in their ears, it does not have to be infected for that to impact the hearing. And that seems to a lot of times be really like an aha moment for families or something that they didn't necessarily know. And they're like, oh, well, we've been to the pediatrician for a well-child check and they had fluid, but the pediatrician didn't say anything about that being an issue. So I'm like, it could be if it stays there. And we don't know how long it's going to stay there. So just another little piece that you can educate families on. Knowledge. Yeah, maybe.
I have a question, and if I'm changing the subject too much, let me know. If a child is not able to get through the screening with you guys because they're crying and they're just kind of not used to it, and the parent wants to try it again, do you guys reschedule with the parent, or do you usually say like, talk to your therapist?
I would say Karen and I do just pull up the
You do,
calendar
okay.
and do that. Yeah, but it sounds like that.
I don't. No, I just say, go home and practice, and then you can get rescheduled with your therapist.
What do you think we should, I mean, I think it's just easier when the parent is already there, knowing that the spots fill up, not super quickly these days. But if we can get them on for the next month, and then I just let the FSC know. Do you guys have a preference of that?
I don't think so. I mean. Whatever works for you guys. Yeah. And I know you guys usually like email us the results. If they weren't, and I haven't had this come up yet, but if they weren't able to go through the screening, do you usually say like, hey, that we couldn't get them through it? Okay, I wasn't sure.
We still fill out a form that just said we
Okay.
accepted it,
Okay.
just so it's documented.
There's little boxes at the bottom of the form, and it's like they passed, or we would refer to the pediatrician if they had fluid, or if they didn't pass the OAE. That's like a bigger concern, because that means there could be like actual hearing loss or more permanent hearing loss. Not necessarily, but it could mean that. So then that would say like refer to audiology, or there's a box that says like could not complete. Got it. Okay. What questions do you all have about hearing screenings or the process, or any other things? Yeah.
Okay, dumb question. Are you able to like eyeball and see if the kid has fluid in their ear? Okay.
Not fluid.
So-
I like, they have tubes. I like to look inside of their ears, so it's just kind of cool, but no.
Yeah.
So how do pediatricians check?
They,
Yeah.
we just don't know enough ourselves as screeners.
Okay.
But can you
We-
physically, like, they can evaluate the eardrum and they know what they're looking for. We just don't.
Years ago, the audiologist, one of the audiologists at Greenbush used to come up once a month and she would do the hearing screening clinic, and she's trained to look for fluid with a little otoscope. So she would do it, but that is something that wasn't in our 9 boxes of scope of practice. Necessarily diagnosing fluid. So, but yeah, the tip is that kind of easy way without having to really get in there, but kids do not like that.
No, we
There
don't
was
do it half
a
the
lot
time.
more crying when Shelley used to come up. A lot of
Like the
crying.
first thing we're supposed to do, I think, and we just.
Yeah, we have, just don't, but we rarely use it.
It's kind of scary looking, so, yeah, I don't blame them. And then it makes them feel like they're at the doctor, and if that doesn't go well typically, then we've already kind of set ourselves up for failure. So, yes, we usually just skip the otoscope and go straight to the more meaningful screening pieces. But we do have one if, sometimes if we can't get the probe to fit, or we already notice like some gunk coming out, we might look in there to be like, oh, this looks like there's a lot of wax, you should follow up with your pediatrician. But I would say that's pretty great. And we do send it to the pediatrician as well. The results.
Where will this be located?
This is in SharePoint. There's, yeah. I'm trying to remember if it's just under hearing. I can make sure it's under hearing and vision screenings as well. There's like multiple folders within the screenings. But it is called hearing screening decision tree. Which means yours is in a different folder, but yeah.
Okay.
We can delete that. Yeah.
It's a workshop. And that's also the same spot where you can find the what to expect letter, correct?
Yeah.
So. let's be sure.
You're welcome.
I think Liv was accurate.
Any design.
Oh, no.
I guess. I think I gotta see.
Anyway, so I just.
I know.
There.